Anatomy of the respiratory system. The respiratory system's main function is gas exchange. First picture, we're just kind of looking at the anatomy of the respiratory system. The first thing I want to define about the function of gas exchange is that you got to be able to breathe. We call that pulmonary ventilation. Just breathing. You take a breath in, you take a breath out. When you take a breath in, that's inspiration. To draw air into the lungs, if you look at the picture, the lung wall is stuck to the chest wall. So that when the chest wall expands, the lungs expand with it. Lungs expand with chest. Because they're stuck to each other. What you're doing is when you expand your chest wall, you're taking a breath in, you're increasing the thoracic volume. That decreases the intrapulmonary pressure. Because the volume has increased, the air molecules have more room to bounce around in, so less pressure. Increase thoracic volume, and as a result, decrease intrapulmonary pressure. That's what we call the pressure of the air inside the little alveolar spaces. Decrease intrapulmonary pressure. You create this negative pressure. We say we breathe by negative pressure, and that draws air into the lungs. This right here, this drop in pressure. Air flows in. For air to flow out, you simply reverse it. When the lungs collapse, when the chest collapses, the lungs collapse with it, you're going to decrease the thoracic volume. Now the air molecules have less space to occupy, and they increase in pressure. You increase the intrapulmonary pressure and air flows out for a breath out. We call that expiration. So the act of breathing doesn't mean gas exchange is occurring, although in healthy lung tissue it is. So the second function is that the respiratory system, it provides a lot of surface area for gas exchange. Provides lots of surface area. We always express surface area in units of centimeters squared. Provides a lot of surface area for gas exchange. So we're always talking about O2, CO2 for the gases. And what we can say is that area where gas exchanges, the surface is actually called the respiratory membrane. A lot of times we illustrate the respiratory system as a little Erwin-Myler flask. So the airway is the neck of the flask, and you deliver the fresh air to the alveolar space. line that area. The point of the ventilation of the lungs is to ventilate those alveolar spaces with fresh air. Okay, so the fresh air is coming in, occupying this space. These are microscopic spaces in the lung, and you got like 600 million of them. Okay, so basically it's a lot. So this is just one of 600 million. 300 to 600 million, there's a range because people are different sizes. Larger people have larger lungs. Well, anyways, you ventilate, but then you have to have this respiratory membrane. So blood's coming in, oxygen poor. The goal is to dump CO2, pick up O2. That's the exchange. CO2 is like a metabolic waste product that builds up into your tissues, but the right heart pumps that blood to the lungs so you can breathe it off. Dump CO2, which can be breathed off, pick up O2 from the fresh air. O2, pick it up. So that blood leaves oxygen rich. It's the job, well, as you should know, it's the job of the pulmonary veins to collect the oxygenated blood and bring it back to the left heart, right? Now, the respiratory membrane is the junction between, this, well, let me kind of, when I say respiratory membrane, it's that little thing right there where the gases exchange, where the alveolar space wall and the capillary wall, they're kind of stuck to each other. That's the membrane that I'm talking about. So then the third thing is the respiratory system, it uses the circulatory system for long-range transport of the gases. Third point I make. 3, it uses the circulatory system for long-distance transport of the gases. So that oxygen-rich blood, it's going to travel to the peripheral tissues, right? So let's say, let me draw a generic cell of your body's tissues somewhere. Blood's coming in, the systemic circulation will deliver the oxygen-rich blood. Gases are just flowing down their concentration gradient. Oxygen is always used by your body's tissues. So you have low oxygen built in the tissue, so oxygen leaves the arterial blood in the capillaries. Right? And CO2 is a metabolic waste product that's building up in your tissues. So the systemic capillaries are going to pick up the CO2. See, it's the reverse, right? At the lung, we call that gas exchange the external respiration. Squeeze it in here. External respiration. We call the gas exchange at the what I call peripheral tissue. That gas exchange is the internal respiration. All right, so in a nutshell, that's kind of the function of this system. By looking at this picture, we can kind of see most of the anatomy we're going to talk about. Let me define some terms here. You have what's called the conducting zone. And you have the respiratory zone. Well, the conducting zone, the main idea is that there's no gas exchange. You're just conducting the air to deep inside the lung tissue to the alveolar spaces. So conduct the air, but no gas exchange. Deep inside the lung tissue, respiratory zone, gas exchange. Occurs. Well, we kind of start with the nose and the nasal cavities. That's kind of where you breathe air in. Of course, you can ventilate through your mouth too, but we teach the mouth as the foodway, not the airway. So it's the nasal cavities that are designed for this. So just to kind of give you a rough outline, nasal cavities, I'll be more detailed as I go through the slides. But you can see nasal cavities, pharynx, larynx, your throat, and your voice box, right? That's pretty much considered the upper respiratory tract. Nasal cavities, pharynx, larynx, upper respiratory tract, part of the conducting zone. So anywhere inferior to the larynx is pretty much lower respiratory tract. So upper respiratory tract, that's when you have like a sore throat or a head cold, you know, those areas that get infected. Okay, now past the larynx are your larger airways. Like you have the trachea and these large bronchi. One trachea, and it divides. You can see the first division of the airways right there. And then the airways disappear deep inside the lung tissue. But what I'll tell you now is that the trachea, along with these larger bronchi plural, bronchus singular, these airways that are part of the conducting zone are called, well, they have high amounts of cartilage. And the cartilage is stiff, so it keeps the airways open, which is a good thing. Cartilage keeps airways open or patent. Patent means open. You ever see that word? Now, with further branchings, the bronchi are increasing in number, they're decreasing in size. The smallest airways are called bronchioles, like arterioles. And they do not have cartilage, but they have smooth muscle. So I'm going to write no cartilage, smooth muscle. Cartilage. Smooth muscle. And the last set of bronchioles of the conducting zone are called the terminal bronchioles. And then the first bronchioles that have the little alveolar spaces are called respiratory bronchioles, and that's where you can start to have gas exchange. And now we're at the microscopic level where you really can't see any of these on this slide. We'll get to it. But the respiratory bronchioles give way to the alveoli, the tiny 600 million microscopic spaces. And so the airway is a dead end, and it ends there. So air just goes in and out. You know, the blood keeps going round and round though. So, well, let's kind of look at the anatomy in more detail here. We'll start with the nasal cavities and the pharynx. The pharynx is shown here behind the nasal cavities. It's color-coded because you have different regions of the pharynx. We just call it your throat. I like this the illustration next to the more detailed illustration. which has some structures you got to identify. The air first enters through your nose. We say external nares, nose. Nose with hair follicles to help trap dust and other particles. And well, when you're in your nasal cavities, this picture shows you the nasal septum that separates the two nasal cavities. And you should remember that it's part cartilage, part bone. That's the vomer, that's the perpendicular plane of ethmoid, if you got to look that up again. The nasal septum. Separates two nasal cavities. And on the picture on the left, you can see the superior, middle, and inferior conchi. These help to slow and warm the airflow before it enters the pharynx. We'll just say conchi slows, warms air. And when you get out of the nasal cavities, this back area that leads to the pharynx is called the internal nares. The internal nares, it goes straight to the first part of the pharynx, which is your throat. It's called the nasal pharynx, which is just behind and below it right there. So this region here is the nasal pharynx. Nasopharynx. In this region, there's a little orifice right there. That orifice goes to the auditory tube. So within nasopharynx, you have orifice to auditory tube. Let's remember what that is. If it goes to the tympanic cavity, right? It's where your eardrum is. It's where your auditory ossicles are. It's your middle ear. But this is how infection can spread from ear, nose to throat. Because this is the throat, that's the nose, and it leads to the ear. You also have a little bit of lymphoid tissue right there. It's called the pharyngeal tonsil. Now the pharyngeal tonsil is lymph tissue. There's other lymph tissue there. Let me continue on with the oral pharynx, right behind the oral cavity. Okay. You see the big tongue there. There's uvula hanging down there. And then there's this little fold of membrane called the fauces. I'll write it down. But within there are your adenoids or your palatine tonsils. So let me continue up here. Oropharynx. I said you have fauces. That has the palatine tonsil in it. More lymph tissue. Typically those are the adenoids that are removed if they become too large and swollen. And also I mentioned the uvula, which is soft palate. Well, that little dangly piece of soft tissue that hangs down. Okay. So the oral pharynx is right behind your oral cavity. You can see why the doctor needs a tongue depressor to push your big tongue down so you can see the back of your throat, see if anything's infected. Because the tongue does occupy most of the oral cavity. The oral cavity is just a sliver here. All right, well, then you have, well, let me backtrack. Nasopharynx, oropharynx, laryngopharynx in green right there. It's pretty much a fork in the road because you route food down the foodway, you route air down the airway. That's why it's a fork in the road. Anyways, the laryngopharynx leads to the laryngeal inlet. Laryngopharynx. Laryngopharynx. So since we're talking about the airway, let's say the Laryngopharynx routes air to larynx. Oh, one thing I forgot. For oropharynx, note the lingual tonsil right behind the tongue. Lingual tonsil. So I'll squeeze that in for oropharynx. Got that lingual tonsil. There are three sets of tonsils. Okay, so there's pharyngeal, there's palatine, there's lingual tonsils, all in the throat. So let me get to the laryngopharynx. Let's look at a different picture now. Talk about the larynx.
I have a question.
Yeah, go ahead.
When they say, when they take your tonsils out, which tonsil are they taking out?
Palatine.
The palatine.
Yeah, those are the only, usually those are the ones that are removed. You have some good pictures in the atlas that kind of show those tonsils really enlarged and inflamed. Okay, in this dissection, what you're doing here, you're cutting this little ligament here, and you're removing the skull head neck off of the vertebra posteriorly. And when you do that, you can cut right through the throat, the pharynx, and you see the concha divided by the nasal septum. I mean, this area will be called the internal nares. You see the uvula, the root of the tongue, and that is the laryngeal inlet. That's how you route air into the larynx down the airway. Okay. Now, the anatomy here is, well, I think I would know these two little bumps. Okay. It's the cuneiform and corniculate tubercles. Those are on your study list. It's part of the larynx. Larynx, cuneiform, tubercle, corniculate. Tubercle. They're just little bumps. Tubercle means bump, and we'll kind of see more of them later. Now, looking at the larynx isolated on the right, and if you remove the mucous membrane off of it and just look at the cartilage that makes it stiff, this picture is a posterior view. That's a posterior view of the larynx with the mucous membrane on it. And the function of this structure are two things: voice production, and you want to guard the airway during swallowing. Voice production, as well as guard airway during swallowing. Alright, let's look at some more pictures here. This is a picture of a model I have. It's this model in this tray here. And try to put it together. I'll put it completely back together, but yeah, I took a big picture of that. There's a lot of useful things you can use to study when you study this model. One is those little tubercles I just mentioned. I like how they show part of the membrane on the larynx, and then this part where it's like blue cartilage, like they strip the membrane away so you can see the cartilage underneath it. What you can see is that there's a little point there, a little corniculate cartilage that makes that bump, and there's another bump here created by the cuneiform cartilage. Let's move on. Okay, this is a side view of that same model. This is a view of the larynx tilted a little bit. I made it match the angle of that the larynx has in the neck. So you can see we're in the neck. There's the carotid bifurcation at the superior border of the thyroid. There's the thyroid gland that we talked about in endocrine. So the thyroid gland got its name after this thyroid cartilage. The larynx is considered anterior neck. The posterior neck would be the cervical vertebra. But we want you to know and be able to identify the laryngeal cartilages. The laryngeal cartilages include the thyroid cartilage, which means shield shape. Now, that whole big thing, I just want you to know that bump you can feel in your neck, we call the Adam's apple. It's right there. It's called the laryngeal prominence. That point right in the middle. It's a surface feature on the thyroid cartilage. Laryngeal prominence. Right below the thyroid cartilage is the cricoid cartilage. They say it looks like, well, cricoid means ring shape. So imagine a class ring, a man's class ring, and that would be the band of the class ring, right? So that's it right there. Tracheotomy, what they do is they'll make an incision through that ligament. I'm sure it has a name, I don't know it. But anyways, if you're choking, you have to bypass the airway for whatever reason. Maybe the patient is having trouble breathing. That's where you can make an incision and insert the tubes so the patient can breathe. So be able to identify those two cartilages. From this view, superior and posterior, there's other things that we see. From the superior view, you can see why the larynx functions as a voice box, because the vocal cords, the vocal ligaments, as they're called here, form this upside down V. And they attach from the inside of the thyroid to these paired cartilages called the arytenoids. So note the paired arytenoid cartilages. Paired, because you got two of them, arytenoid cartilages. And notice the horn tips on top of the paired arytenoid cartilages right there and right there. Those are the corniculate cartilages that created those corniculate tubercles you just noted. So they're also paired, so I'll put right under it, paired corniculate cartilages. Okay, but we should note those vocal ligaments. For voice production, obviously, they're called vocal ligaments. Well, the anatomy is they attach from thyroid cartilage to arytenoid cartilages. Attach to thyroid and paired arytenoid cartilages. And so on the posterior view, they have those little arrows indicating that the cartilages move. The arytenoids can pivot back and forth to move the vocal cords. And what happens is, when you take a breath in, the vocal cords are abducted, they're separated. And the space between the vocal cords or vocal ligaments is called the glottis. Glottis. Space between vocal cords. If I say vocal cord, same thing as vocal ligament. All right, the other thing can we see from this slide in the posterior view? We see that there's an epiglottic cartilage that will cover the glottis during swallowing. So that's why it's called epiglottis, which means above the glottis. I'll just write under glottis, epiglottis, which is a cartilage. Its function is to cover glottis. When you do that, you guard the airway during swallowing, which I already wrote. Okay, that's the guard. Prevents you from getting food down there. So I'm going to move on. All right, so this picture, it shows a sectional view of the neck and just the larynx behind it. So you can kind of see how it lines up. It's hard to identify things here when you're learning it. It's easier to see things here when you're learning it. The larynx is just this part. There's the thyroid cartilage. There's a cricoid cartilage. There's that little ligament in between them for tracheotomy. These two ligaments, the one I mentioned, this bottom one, is the vocal ligament. The one on top of it is the vestibular ligament. So let's kind of talk about those. So when I talked about the vocal ligament or vocal cord, have you ever seen the term true vocal cord? They're referring to these. So you can also call these, quote unquote, true vocal cord. Sometimes I see them called vocal fold. All these things. Vocal ligament, vocal cord, true vocal cord, vocal fold. They call it fold when you put the membrane over the ligament. Vocal. And you can call it any of those 1, 2, 3, 4 things and you'll get it right. It all means the same thing. The ones that produce sound, the vocal cord. Just remember it's the one on the bottom. I think that's what you'll have trouble with, right? Which one is it? Well, you got a 50-50 shot. The one on the bottom. Now the one on the top is called the vestibular ligament. Also known as the false vocal cord, not involved in voice production. Or you can call it the vestibular fold. When you got the mucous membrane over it, because when you put the mucous membrane over it, they look like lips. Do you see them? Do you see the lips? Well, that having been said, what's the bottom lip? The vocal fold. So the top lip is going to be the vestibular fold. But again, I don't care what you call it, any of that, or it's got to be one of those. I guess I give you credit for it. Now the function of the vestibular ligament, it kind of part way helps guard the airway. It's kind of like a little shelf above the airway. So it's kind of like protecting the airway a little bit. Protects airway. Here's a picture of the isolated arytenoid. Arytenoid means pitcher. Does that look like a pitcher? Pour lemonade from there? I don't know. They always name these things for what they appear like. Arytenoid, remember that. Corniculate, little horn tip on top. Know that too. Here's a laryngoscope view. I've seen paramedic students intubate cadavers. I run one of their anatomy labs, and that's what they look for. They look for that little upside down whitish V. Has anyone ever intubated? Oh, you have? Have you seen that? Is that what it looks like?
Yeah.
Do you see whitish things?
A little bit. Yeah.
Okay.
It's more white, but it depends if like there's a bleeding.
Do you ever inflate the stomach?
No.
Okay, good. I've seen the paramedic students do that. We have the whole body cavity open, so it's easy to see the stomach inflate. But even they're pretty good. They can do it. They take that. What do you call that metal blade again?
I call it a crank, but.
You call it a crank?
Yeah.
Is that what it's called?
No.
Okay. Well, yeah, it looks like a crank. But I'm always told that you want to, like, when you insert it, you kind of want to lift forward. Like when you say cheers, like you don't tilt, right? Because you'll spill your drink. But if you do that with the metal blade, you can break molars. Okay? So you need to be careful. That's training down the line. But anyways, that's kind of the view you look for when you intubate, because that's the airway. The glottis is the airway, and so that's where you got to put your tube through. So our model, if you look right down the gullet there, and you're looking for those whitish vocal cords. That's what you're seeing there. So in this picture here, the whitish vocal cords are flanked by the vestibular folds. See it right there? That's why it's like a little shelf. So if something falls, hopefully it falls this way, right? Not down the airway. That's why I'd say it kind of sort of protects the airway. Let's move on. So when the vocal cords are open and you got the glottis open, the air rushes in. And then when you speak, air is forced to whistle through a closed glottis, and that produces the sound. You just vibrate your vocal cords. So here's a picture of the model, and you can see the bottom one is the true vocal fold. The vestibular fold, again, see, it creates a bit of a shelf, kind of catch things. Well, there's a real picture of air rushing in. The vocal cords are open. And so talking is actually the intermittent release of exhaled air. You force air to whistle through that slit. And well, upon inhalation, the vocal cords open, air rushes in, and then upon exhalation, vocal cords closed. Air is forced to whistle through a slit, vibrating the vocal cords, producing sound. So that's why when you inhale that whole helium balloon, it makes your voice all high and whining, which is fun to do at parties. But the gas is like vibrating your cords at a higher frequency. That's all it's doing. Let's see here. All right, so pitch is determined by the length and tension of the vocal cords, and loudness is the force at which the volume of air rushes across the vocal cords. And, well, the other things, the other anatomy, the pharynx, nasal cavities, they resonate, amplify, enhance sound quality, and finish it off by forming the sound by shaping it with the action of your tongue, soft palate, and lips. Okay. Now there's a couple of muscles I want you to know that control the vocal cords. We'll just do one on the front and one on the back. So these are laryngeal muscles. So the one on the front is cricothyroid. Cricothyroid. These muscles are named for what they attach to, right? That's one way you can name the muscles. Okay, then the other one, the one on the back, well, that's why they call it posterior. Cricoarytenoid. Now the innervation is superior inferior laryngeal nerves, and so the cricothyroid is innervated by the superior laryngeal nerve. I got a picture of it there. It's a branch. These are all branches of vagus, and vagus branches into the recurrent laryngeal nerve, which gives this superior laryngeal nerve branch. Let me just write that. So it's innervated by superior laryngeal nerve. Now on the left side, as a side note, on the left side, this superior laryngeal nerve, it branches out the recurrent laryngeal. It's recurrent because it has to pass under the aortic arch on the left side right here. And the reason why that's important, so on the left side, all right, recurrent. Laryngeal nerve passes under aortic arch. If you have an aneurysm in that location, the patient may present with a hoarse voice because it's affecting, you know, these muscles of the larynx. So hoarse voice may indicate an aortic aneurysm. You want to get to that thing before it bursts. Now, the function of this muscle is to tense vocal cords for higher pitched noises. So I point to that little screw in the model. This is a functional larynx because as this muscle contracts, it tilts the larynx, it tilts the thyroid cartilage forward. And in doing so, you kind of tense the vocal cords inside, okay, for high pitch. So if you go like, you can feel it, right? Everyone go like this. Just kidding. But you feel something, right? To make that noise, it's effortful. It's voluntary muscle. Now, the one on the back I want you to know, okay, that's the posterior cricoarytenoid. It's innervated by the inferior laryngeal nerve. Inferior. And it abducts the vocal cords. That's its job. It's going to pivot the arytenoids right there. So that's kind of me pulling on the arytenoids. It makes them pivot to abduct vocal cords. Now, to my knowledge, is the only one that does that. That's a pretty important muscle because you'll have trouble breathing if you can't abduct the vocal cords. There's a picture of the model with both of those nerves labeled, superior and inferior laryngeal nerves. One more thing about the glottis is the Valsalva's maneuver, which is straining against a closed glottis. How about the what? Right there, Valsalva's. That's the guy's name, I think. Strain against a closed glottis. You know when you grunt, effort, right? So when you're doing that, that's this. Just a fancy way to put it. And what you're doing is you're temporarily trapping air in the lower respiratory tract by closing the glottis, and it kind of like it causes an intra-abdominal pressure to increase, especially when you contract the ab muscles. That'll help you, go number 2, empty the rectum. But also when you lift heavy loads, it kind of like splints the trunk. Okay. It also increases blood flow to the head. I remember when I was a student, this is one of the ways that they trained fighter pilots. When fighter pilots have to like kind of tilt their fighter jet down, the G-forces are so strong down, they can't pump blood up to their head and they black out. And so any of the flight suit helps, but also they train by increasing the musculature in the head neck region, and they do this, they just kind of grunt, and it prevents them from blacking out. So that's one of the super physiology things I've learned about this maneuver. But just for us driving up to the mountain and your ears pop, you can kind of do that to help equalize middle ear pressure too. All right, let's do the trachea next. Actually, this is a good spot for a break. A break here.